So good morning. I'm Dr. Amanda Hedinger, a local psychiatrist with Norton Women's Mental Health Services. Today, I have the honor of introducing Dr. Rina Perlin. I had the opportunity to meet and work with Dr. Perlin in the past year as she has explored her interest in women's mental health. Earning her undergraduate degree in biology and a minor in creative writing at the University of Louisville, Dr. Perlin spent a year at the University of Washington in an exchange program and honed her fluency in Spanish, pursuing a certificate as well with the official language school of Salamanca, Spain. She then completed her medical degree at the University of Louisville School of Medicine. During that time, she was recognized with the S. Spafford Ackerley Award during her psychiatry clerkship, received the Alpha Omega Alpha Senior Medical Student Award, and the Gold Humanism Honor Society University of Louisville School of Medicine Above and Beyond Award for exceptional humanistic character. I am confident the department was pleased when she chose to continue her residency here at the University of Louisville. During her time within the department, she has received awards for her outpatient work and with the VA. In 2020, she notably received the American Medical Women's Association Eleanor T. Christensen, MD, Altruism Award. It has been my pleasure to spend time with Dr. Perlin. I've been impressed by her compassion for patient care and intellectual curiosity. These were my personal impressions, and I had not viewed her impressive CV until after that. Dr. Perlin has carried an interest in women's health from early in her studies, beginning with research and publication in medical school. She has continued to explore these interests in residency as well through research, seeking clinical opportunities, and gravitating toward work that also resonated with this in the context of her psychotherapy training. I am confident today's presentation will be informative and thought-provoking. As one of our outstanding educators, Dr. Al-Malik, instilled in me years ago, we should hone in on the topics that challenge our existing views. Reproductive psychiatry and caring for pregnant women in 2023 likely challenges a number of tenets that have existed historically within our field. With that in mind, I'm looking forward to us all learning from Dr. Perlin's presentation today. Thank you.
Thank you so much for that introduction, Dr. Hedinger. I'll just start by sharing my screen. And as requested by Christy, I will share the CME document very briefly. Let me know if there's any problems seeing this. And then I'm going to go over and start my slideshow. And at any point, anybody who's a panelist can jump in and let me know if they're not seeing my slides. All right, so I'm Rina Perlin. I'm a PGY4. This is my Grand Rounds presentation. And we will be talking about relapse prevention, specifically for bipolar I disorder in pregnancy. Hope you all have a copy of the objectives. Essentially, we'll hopefully establish that relapse prevention is our primary goal when we're managing bipolar I in pregnancy. We'll talk about the risk versus risk discussions involving medications in pregnancy and breastfeeding. We'll consider symptom monitoring and the adjustments and treatment that we may need to do throughout the course of pregnancy and postpartum. And then we'll also focus on lifestyle risk management and other therapeutic interventions during and after pregnancy. All right, so picture this, if you will. A patient comes into your office with the following questions and concerns. I'm ready to get pregnant, but I'm really not sure what to do about my medications. I'm terrified of getting sick again. How will these medications affect the baby? Should I breastfeed? And maybe on the patient's mind is, will I be able to handle it all? And it's possible that as you heard these questions, that question is kind of on your mind too as a psychiatrist. So these are decisions where there are a lot of unknowns and there are a lot of competing risks. And so we really have a situation where there's no one best answer necessarily, and there's certainly very few risk-free options involved. So in that context, I'm going to borrow a phrase from Dr. Hedinger that I've learned from her during my work with her, which is the sense that in this context, the complexity of these decisions, we really have an opportunity to house ambivalence, a role of housing ambivalence for our patients. So being a container, if you will, for all the uncertainties involved in these decisions, while helping the patient feel well-informed and confident in the choices that you make together. So how will we kind of structure this presentation? Well, we'll have a fictional case that will follow from preconception through postpartum. And we were to have multiple choice poll questions related to this case and hopefully some participation. So it turns out the poll function is not going to work in this presenter mode, but I'm still going to put the questions up and hopefully you can participate by thinking deeply about the questions as you see them on the screen and kind of considering what your answer might be if you had to answer a poll. And then hopefully through the course of working through this case, we'll be able to talk about some practical and evidence-based recommendations and give a sense of what our guiding principles are when we're making decisions. All right, so why is this relevant? And when do we need to start talking about pregnancy in women with bipolar I disorder? In other words, we know about all these periods throughout the lifespan and the periods that we talk about during pregnancy, but when is the preconception period? When do we have that opportunity? So just a little bit of background on bipolar I disorder specifically. We know that there's a lifetime prevalence of probably a little bit over 1% across the sexes. On average, incidence peaks in the 20s through the 30s, so prime years of fertility for women. We know that women have a later average onset of disease and unfortunately longer average delays in diagnosis. And this is related to a number of factors that we probably don't have time to get into today, but one of the things I'll mention is that on average, women are more likely to have an incipient depressive episode rather than a manic episode. And as you can imagine, this might lead to a delay in getting a bipolar I diagnosis. I'll also mention as part of the context that over half of pregnancies in this country are unplanned, and that is certainly greater among women with severe mental illness. And I think we need to all agree as part of this presentation that unintended pregnancy is not a risk-free situation, especially when we're considering women with severe mental illness. Unintended pregnancy can bring a number of undesirable outcomes for the patient and the patient's family, from increased morbidity of psychiatric and medical illness, precipitously going off of medications, which is something that we'll discuss, and really outstanding socioeconomic consequences as well. So what does this mean for us? Well, essentially what I'd argue is that it means that our opportunity for preconception counseling is throughout the majority of the fertile lifespan outside of pregnancy. If all these things are true, then we can assume that there's a pretty high likelihood that patients are going to become pregnant, likely unexpectedly on the medications that we prescribe. I'll also add that the majority of women don't realize that they're pregnant until well into the first trimester, about 6 to 8 weeks. So we have a responsibility to think about the reproductive safety data on these medications really at the time of diagnosis, at the time we start these meds. And it is an issue of informed consent, particularly for women who have plans of becoming pregnant at any point in the future. So we want to discuss plans for pregnancy and, if appropriate, contraception at any opportunity. And then if you have an outpatient, it's relevant to document the first day of their last menstrual period at each visit. On an inpatient basis, we usually get a pregnancy test. All right, I'm just going to breeze through this slide fairly quickly. My main point in talking about contraception is that this is a collaborative process of decision-making, but we don't know what to do if we don't ask. So it's really critical that we ask all of our patients of reproductive potential, do you want to become pregnant? And if the answer is no, really having an in-depth discussion about contraceptives, especially in bipolar disorder, given the agents that we use and their risk if a patient were to become pregnant. I'll mention that long-acting reversible contraceptives, LARCs, which include the IUD and the subdermal implant, are extremely effective. They have a perfect use failure rate of less than 1%. Over 10 years of perfect use, the risk of becoming pregnant on a LARC is less than with sterilization, but they're rarely chosen. Only about 14% of women on contraception in the US as of about 2016 would choose a LARC over something like a birth control pill. So we have an opportunity to discuss all options with our patients and also the efficacy of those options. When it comes to combined hormonal birth control pills, This is a particularly relevant point in bipolar disorder because of the interactions with the antiepileptic drugs. So just very briefly, for example, combined oral contraceptives can lead to significant decreases in serum lamotrigine, 25 to up to 50% decreased level. So that often necessitates that women have their level significantly increased if they're on a combined oral contraceptive to maintain mood stabilizing efficacy of Lamictal. And then Tegretol and Trileptal can significantly decrease the efficacy of combined oral contraceptives. So something to just certainly keep in mind when we're talking to these patients. And I'll just add as an additional bullet here, and this will kind of be sprinkled throughout the presentation because I think it's one of the most important things that we can do for harm reduction, is that any woman on antiepileptic drugs should be on at least 4 milligrams of folate daily to decrease the risk of neural tube defects. So with all of that in mind, let's meet our patient. So her name is Maya, and her age is 30. She has not had any previous pregnancies, and she presents with her husband for a 1-hour intake visit in your office. And their chief concern is, we want to become pregnant. She has a diagnosis of bipolar 1 disorder. She was diagnosed at age 22, and her current medications are lithium 600 milligrams, risperidone 2 milligrams, and quetiapine 300 milligrams. So here's our first poll. So pretend that you're submitting an answer to this, if you will. So based on the limited information that we have now, what is your next priority or your top priority during this first visit with the patient? Are you going to focus on clarifying her diagnosis and eliciting any current symptoms? Are you going to discuss medication and the risks and benefits associated with them? Do you think you might discuss some lifestyle modification to help prevent relapse? Will you order basic labs? Or will you elicit patient preferences about medications and pregnancy? And as with these decisions in real life, in this poll, there is probably not only one correct answer. Ultimately, we probably will do most, if not all of these things, but I think it's worthwhile to get a sense of where our highest priority is. And I have a sense for me. So just take maybe 5 seconds to think about your answer to this question, and then we will move on and see what more information we can get. All right, so let's see. So this is a preconception counseling visit, ostensibly. So I consider this to be a wonderful opportunity in this scenario, which actually does happen. I know based on our inpatient work and our consult work, where we often encounter people who became pregnant unexpectedly and didn't have this opportunity to plan. It doesn't seem like it, but patients actually do plan for pregnancy. Bipolar patients plan for pregnancy as well, and they may very well come to your office and ask these questions. So there have been no first trimester exposures yet, and there really is this precious chance to make some reasonable plans for management during pregnancy. And really, if you think about it, we actually have this opportunity to discuss these things with any patient of reproductive potential at any time during their illness. And it may be comforting to us to know that we have that opportunity to do so in advance. So I think that diagnostic clarification is kind of the keystone of this preconception visit, especially if you're meeting a patient for the first time. You really have an opportunity to get a detailed history, collateral, record review, and of course your initial interview and exam to get a sense of whether this patient's pre-existing diagnosis is accurate. We can use validated screening tools like the mood symptom scale to screen for a history of hypomania or mania. Some folks recommend doing this along with the EPDS for postpartum women who may be at higher risk of having a bipolar diagnosis missed, for example. But what this allows us to do is say, are the current medications appropriate? How effective have they been? And what is the underlying thing that we're treating? Is there an opportunity to simplify this regimen even outside of pregnancy? But now that there's pregnancies, there's actually another reason to really clarify things. We want to get a sense of the patient's baseline and current functioning. How sick do they get? What are their symptoms like off medication? How are they doing currently? Any current symptoms? We want to assess what resources the patient has. So critically, this is going to involve finding out who the patient support system is, and from the beginning, getting a release of information so that in case of any emergency, you have the option to contact any people that the patient considers to be relevant support persons. Resources would also include what are this patient's financial resources, their educational background, what kind of inherent coping skills do they have they had any therapy exposure, those kinds of things. Next, we want to think about what are the other relevant exposures for this patient if she's to become pregnant. So not only her psychiatric diagnoses and her psychiatric medications, but does she have any comorbid medical issues associated with those medical issues? Is she on any medical agents that could be significant in pregnancy? Very critically, we screen for substance use, highly important exposure during pregnancy and breastfeeding. We want to think even possibly about coordinating with her primary care doctor and OB to think about any environmental exposures. In Louisville, a relevant one would be, are you in an older home with lead paint, for example, or any chemical exposures at work, things of that nature. Obviously, this is our first opportunity to talk with the patient about their preferences, their concerns, their deepest worries about their medications in pregnancy and breastfeeding as well. So from the beginning, we want to discuss breastfeeding because it may affect our choice of agent throughout the entire pregnancy if we know that we're just going to have to change a risky medication after delivery to suit the safety in breastfeeding. So we want to know about that from the top so that we can make a good plan. And then we want to ensure optimal treatment, as we talked about. So getting clarity on the diagnosis, simplifying, reducing polypharmacy if and as able, making sure that we address any current symptoms that the patient might be having, and all of this with the goal of helping the patient be as psychiatrically stable as possible before conception. And a lot of this will involve early coordination with OB, MFM or high-risk OB if applicable, primary care. There are some recommendations that women maintained on some of these medications be seen by a high-risk OB, and we will get into that a little bit more shortly. All right, so back to Maya. So we've conducted our interview, and it turns out that her history does reflect true bipolar 1. She had her first depressive episode at age 18. It was a severe episode that involved a suicide attempt, a manic episode at age 22, after which she was hospitalized and stabilized on lithium and risperidone and diagnosed with bipolar 1. And then a manic relapse at age 25 in the context of coming off of her own lithium and doing some third shift work that was very disruptive to her circadian rhythm. So let's imagine that this is kind of an ideal scenario and we somehow had recent labs from the primary care doctor or another psychiatrist or OB before she came in for an intake with us. So all of her basic labs and medication associated labs are normal, and her lithium level is currently 0.6. She and her husband also disclosed that she's been having some kind of mild subsyndromal symptoms for the past 3 weeks, even though she's been treatment adherent. She's been more irritable. She's had some mild psychomotor agitation, a little bit of increased activity. Nothing severe, but they have been a little bit worried about it. And this is in the context of some financial stressors and then trying to get everybody ready for pregnancy. And she's worrying pretty intensely about pregnancy and the effect it could have on her mood. And then very relevant in her support system includes her husband of 2 years and her mother. All right, so another poll for your imagination here. So based on the additional info from her past history and her HPI, what would you do next in this case? And again, in this visit, we may hope to accomplish several of these things, but what is your real priority here based on the information that you have? So would you recommend medication adjustment today? Would you counsel Maya about the risks versus benefits of her meds in pregnancy and breastfeeding? Do you talk about maybe some ways to adjust some of her lifestyle risk factors, get her referred to psychotherapy as well to help with that. Would you talk about contraception at all? So just think where you might end up if you were forced to prioritize just one of these. All right. So it will become obvious as we move on to the next stage in this case that my priority is going to be, as we said, making sure Maya is as psychiatrically stable as possible before conception. So priority number one is going to be adjust her medications to treat these subsyndromal symptoms. We're not going to ignore them. We're going to consider them a sign that her medication is not totally effective at this point, and that we should make some adjustments. So to wrap up her first visit, what we did is we titrated her lithium to 900 from 600, and we continued her 2 antipsychotics just to make not too many med changes at once so we can make sure that we're doing the right thing. I would refer her for psychotherapy, and we would start talking about symptom monitoring and lifestyle management, which we'll cover in the coming slides. And then we'll also introduce this risk consideration involving her current medications. We'll also talk about that in the coming few slides. And then at the end of this visit, we discuss, based on Maya's personal preferences, she doesn't feel ready to conceive yet because she has these mild symptoms that she wants to control. And then she'd also like to, if possible, simplify her regimen before she conceives to decrease the risk of exposures. In the interim, she plans to use condoms for contraception. All right. So a brief word on lifestyle risk factor modification to aid in relapse prevention. So this is not just a conversation about medications. It never is. We've got some real therapy skills, lifestyle skills that we can deploy to contribute to our relapse prevention efforts during and after pregnancy and outside of pregnancy. Again, just to hit it home one more time, we want the support persons involved in this effort from the beginning, including in this lifestyle modification project. And we want to make sure that we have an ROI so we can call in case of emergency, or so that they can call and talk to us. So the first step is going to be discussing a symptom monitoring plan with the patient. Hopefully they'll be able to do more of this in their actual psychotherapy practice. But what that might involve is recommending for more psychologically minded patients who are interested in getting involved in this process, some kind of self-help manual for bipolar relapse prevention. Something like the Bipolar Workbook by Dr. Basco is something that I highly recommend, and it will be in my references. And so we may do something like a symptom summary worksheet in early therapy visits. So that would be discussing kind of the gradient of what their previous symptoms have looked like for depressive episodes and for manic episodes. So for any given symptom in one of those syndromes, for example, let's say paranoia, for example, for a manic symptom, they may rate a mild, a moderate, and a severe version of that symptom. And mild might be, I get a little bit more worried about what other people think of me. I get a little bit more on edge. Moderate might be, I start to worry why my husband is asking me certain questions. And severe might be, I come to believe that my family is involved in a conspiracy against me, for example. But we can do that with any number of symptoms: sleep, activity level, psychomotor symptoms. And it's good to get a sense of this when the patient is euthymic and can reflect on them, and then share with the support system so that everybody has a chance to tune in and recognize these symptoms if they're present. We also encourage a mood log if possible. So this is somebody rating how far or close their mood is to euthymia on a given day. And it usually starts with 0 as euthymia, negative numbers down to severe depression, positive numbers up to severe mania. And this allows us to track mood over time and notice if there are any concerning patterns developing. And then also having a tiered response plan depending on the severity of symptoms. And this is essentially a CBT-based practice. And then as far as managing the modifiable risk factors for relapse, we want to focus as much as possible on medication adherence. We can definitely use some cognitive methods and behavioral methods to help with this. You want to know if the patient has any beliefs that might lead them to be non-adherent with medication. Keeping a good focus on maintaining a circadian rhythm with sleep and activity levels, stress management, so coping skills, mindfulness, again, activating the support system. And then this is pretty critical, planning for the likelihood that triggers for relapse are going to occur, regardless of pregnancy, but especially during pregnancy and most especially in the postpartum period. We know that there will be triggers for relapse. There will be stressors. There may be seasonal triggers. There may be work shift changes, but especially there will be triggers related to nighttime childcare. So how can we plan for those? And can we moderate those risk factors at all with the help of our support system and planning ahead? And then also identifying any substance use and addressing that to ameliorate any risks that might contribute towards relapse. All right, so I know that there is a lot of text on this slide. It's very busy, but please bear with me as we go through it because this is one of the most important slides in the presentation. It's where we're going to try and establish the risks against which we weigh the risks of medications in pregnancy, and hopefully explain why we might even tolerate some of the risks associated with medication if it means keeping mom euthymic during and after pregnancy. So on that note, I've quoted Dr. Lee Cohen, who's kind of a preeminent reproductive psychiatrist with MGH, who often asks this question, compared to what? So in other words, if we're considering the risks of our interventions, what are we comparing those risks to? Because the risks of non-treatment or inadequate treatment are not zero, and they're actually pretty significant and extensive. So let's take a look at that. So on one column, we have the risks of non-treatment or inadequate treatment, which are essentially the same thing. And then on the other column, we have the risks of medications in pregnancy. So across a number of registry studies, systematic reviews of cohort data, we have a current estimate that there is up to a 70% overall risk. So regardless of medication adherence or not, overall risk of at least one recurrence during pregnancy for both bipolar 1 and bipolar 2 pooled. These relapses in the literature turn out to be mainly depressive during pregnancy, and the majority of them occurred in the first trimester. So that's going to be pretty relevant when we talk about impact of medications throughout the course of pregnancy a little bit later on. It turns out that discontinuing a mood stabilizer prior to or during pregnancy confers double the risk of recurrence during pregnancy. It involves a much shorter latency to relapse, up to 4 times shorter, and up to 5 times longer duration of episodes in pregnancy. With abrupt discontinuation, that latency to relapse is remarkably fast, up to 11 times shorter with abrupt discontinuation. So what might this mean for pregnancy? Pregnancy is 9 months on average. And so if you can imagine the duration of episodes that we're talking about and how quickly they come on, you may be looking at situations where the mother is pregnant for the majority, is symptomatic for the majority of her pregnancy. So something that we would really like to avoid if possible. And why is that? So there's essentially no such thing as a non-exposure. As much as we worry about the exposures associated with our medications, we really need to consider the exposures that are associated with an acute mood episode during pregnancy. Morbidity and mortality, of course, we're aware of, but how about hospitalization and the exposures that come along with that? How about the medication exposures that are associated with acute treatment of an acute mood episode? PRNs, higher dose medications for acute stabilization, polypharmacy involved in managing the different agents involved in stabilizing an acute episode. Will there be more extensive measures to manage agitation during a hospital stay? We all know that that's probably the case. What effect does each acute episode have on the overall course of this patient's bipolar illness? Is it going to contribute to increasing severity of the illness long-term and chronicity? Is this relapse going to prompt any additional substance use and exposure associated with that? Will there be potential medical illness associated with this episode? Could there be psychiatric sequelae from a manic relapse? And it's been suggested, and I think it's probably accurate, that there can be post-traumatic symptoms associated with bipolar episodes in the aftermath. What are the socioeconomic outcomes of having a manic or depressive relapse during pregnancy? And not to mention, if someone is severely ill, what does their prenatal care look like? So just some other fetal and maternal exposures to consider. I will just briefly mention that, it has been suggested over the years that the condition of pregnancy, the physiological condition of pregnancy, may be protective against more severe or frequent episodes for women with bipolar 1 disorder. Specifically, this has been reported for women with true bipolar 1 lithium responsive bipolar 1 disorder. However, I have to say that in my reading and my experience, this is not borne out. It's certainly not well demonstrated in the broader literature. And what we know is that the context of pregnancy and all of the risk factors associated with pregnancy tend to actually exacerbate the risk of relapse, especially when it comes to medication discontinuation. And so we really need to, for the purpose of this presentation at least, state that I do not really consider pregnancy to be overall a protective time for women with bipolar 1 disorder, given the associated risk factors. So moving on, I do want to mention, that bipolar disorder itself has been associated with a number of problematic complications of pregnancy. So preterm birth, gestational diabetes, preeclampsia. Untreated bipolar disorder confers a higher associated risk of preterm birth, C-section, placental abnormalities, antepartum hemorrhage, preeclampsia, compared with treated bipolar disorder. And then I really want to emphasize that the affective state of pregnancy during pregnancy very closely predicts the postpartum affective state, which in turn predicts child neurodevelopmental outcomes actually quite well. So if we maintain euthymia during pregnancy, we have a much higher likelihood of maintaining euthymia postpartum, and this has a significant impact on child neurodevelopmental outcomes. All right, so let's talk about the risks of medications that we're going to consider. So we have to think about the risks to the fetus, so in utero risks. Knowing that there is a baseline congenital anomaly risk, congenital malformation risk in the general population without these medications exposures of up to 4%. But when we think about the risks of medications to the fetus, we want to think about several things: congenital malformations or morphological teratogenicity, what some groups call functional teratogenicity, so not necessarily structural changes to organs, but change in their function. So this would include functional CNS changes, functional brain changes, which would include neurodevelopmental outcomes. We want to think about other neonatal outcomes. So is there any neonatal distress shortly after delivery, NICU stays? And then we do consider how much medication passes through the placenta and what the risks are associated with that. We also want to think about other gestational complications. And then we want to think about what the maternal risks are with these medications and whether those in turn confer any additional associated risk onto the fetus. And since we're talking about pregnancy, I'm going to share this old image that everyone's very familiar with from embryology. Don't worry, there is no quiz on this slide. I just want to bring it up to emphasize that the risks of exposure, regardless of the type of exposure, whether it's a medication-associated exposure or another type of exposure, are not equal through the course of pregnancy. So the timing of exposure really matters. This version is from mothertobaby.org, and I like that they delineate between the structural period of concern for structural deficits versus the period of concern for functional deficits. So we want to consider that even when we think an organ is fully developed in pregnancy, there's still quite a bit of opportunity for functional problems based on certain exposures. All right, so just a brief comment, and I will kind of zoom by this one, but my slides can be available to anybody who wants them, who wants to go back later. Just a brief comment on the quality of the exposure data that we have, just to say it is not ideal. We have neither enough data nor the type of data that we really would want to make the most informed decisions about these exposures. So essentially, we have huge issues with reporting bias. A lot of our information comes from kind of this serendipitous self-report data in drug registries, single case reports, small case series. We do have some cohort and case control studies, but they're typically a very small size. And then meta-analyses of registry and cohort data. What we'd really like is to have observational data that's as high quality as possible, and this would vary depending on the outcome that we're looking at. Randomized controlled trials will always be difficult in pregnancy, but high quality observational data would be really fantastic. And fortunately, there are some very large drug registries going on right now. The Massachusetts General Hospital is conducting drug registries for a number of agents in pregnancy. And then there are some very large and growing European registries as well that seem pretty promising. Regardless, any report based on that data is going to have to do pretty extensive work to report or control for or adjust for the extensive confounding factors that are involved in these studies. So from the impact of what the maternal diagnosis is, associated medical concerns, substance exposures. We've got multiple medication exposures rather than single medication exposures. Any other demographic information that you'd care to input. So the list kind of goes on and on when it comes to confounding factors in this data. I just bring this up to give us an idea of what we really know and the quality of data that we have. And we kind of do the best at counseling that we can with what we have. All right. So when it comes to this risk consideration, let's start with lithium, since that's the mood stabilizer that Maya is on. So back in the 1970s, we had the Register of Lithium Exposed Babies, and this was an international registry. And at that time, in the early 70s, the risk of Epstein's anomaly with first trimester lithium exposure was estimated to be 400 times higher the baseline general population risk of Epstein's. And the overall cardiac risk was considered to be 5 times higher. So fortunately, newer, more systematic data with more clarity on confounding, more adjustment, et cetera, is not quite as frightening, but I will say that there still does appear to be a fairly significant overall malformation and cardiac malformation concern with lithium, especially in the first trimester, and especially at doses of 900 milligrams or above. So I've listed here a couple of studies with decent cohort data, Patorno study from 2017 that showed an adjusted risk ratio of 2.66 for right ventricular outflow tract deficits overall, which would include Epstein's. And then for non-Epstein's cardiac risk, they're estimating maybe 1 to 2 additional cases for 100 exposures. So certainly significant and certainly something to discuss with patients. And then a 2018 study in the Lancet indicated, interestingly, an associated increased risk of major malformations besides cardiac malformations in pregnancy with first trimester exposure. So if we're going to continue lithium in pregnancy, the recommendation is that we assess whether any poor cardiac outcome has occurred with a level 2 ultrasound and fetal echo around 20 weeks gestation. And so this risk information leads us to make some decisions with the patient. Again, depending on their background, how they've done when tapering off of lithium in the past is critical to know. But there may be a consideration for using an alternative agent in the first trimester, and then resuming lithium potentially in the second trimester. Some people may not want to be on it during pregnancy at all. And these are all things that we have to weigh. But I will say that the risks of coming off of lithium in a lithium responsive patient, as we know, are fairly high. Higher if we come off of it abruptly, but high nonetheless. All right, and then maternal risks with lithium, we're fairly familiar with. The thyroid and renal risks, obviously. And then pregnancy is associated with potentially higher risk of lithium toxicity, depending on dose, but there is a concern for increased dehydration risk during pregnancy. Any diuretic use we have to be aware of. We want to avoid NSAIDs and other renal exposures in the third trimester. And then preeclampsia, it turns out, is an independent risk factor for lithium toxicity during pregnancy. Fortunately, so far, based on the information that we have, there doesn't seem to be an association of lithium with gestational diabetes, preeclampsia, postpartum hemorrhage, or increased C-section rates. So ideally, what this tells us is that we probably need to increase our lithium level monitoring and our awareness of maternal symptoms and toxicity symptoms as well during pregnancy, with at least a monthly lithium level. And then really ideal would be to get a weekly level in the third trimester, and we'll talk about why in a little bit. But essentially the changing lithium levels during pregnancy, for safety, we probably would want to get a weekly level. Really not practical for most patients, but it may be an option with the weekly OB visits toward the end of pregnancy. All right, so another agent that's commonly used in pregnancy is lamotrigine. It has become a preferred agent because the available safety data is really encouraging. We need to, again, weigh that exposure data against why we're prescribing the medication. So lamotrigine, not as effective at treating or preventing manic episodes. Let's keep that in mind. Probably not as effective at treating acute depressive episodes, probably does better at preventing depressive episodes. So certainly something that we can consider during pregnancy, consider switching someone to if there's time, but you really want to try and use the most effective medication that you can. And for lots of patients, lamotrigine will be a great option. As far as the risks to the fetus, the data that we have now, again, is very encouraging. Major malformations seem to be about equivalent with the baseline risk. There was a risk signal in 2008 from some registry data for cleft palate, but fortunately, a number of subsequent studies with high-power cohort data from European registries showed that there really is not an associated risk with cleft palate, fortunately. Also, so far, there's no indication of adverse neurodevelopmental outcomes with lamotrigine in pregnancy. We do want everyone on an AED to be on high-dose folate during pregnancy regardless. And then in addition, the maternal risk profile and gestational outcomes also look pretty good with Lamictal. I'm going to be very brief going over this slide on the other AEDs in pregnancy. Depakote should be avoided in pregnancy if in any way possible. It is the highest major malformations risk, highest adverse neurodevelopmental outcomes risk. This does appear to be dose dependent. So doses over 1 gram daily were higher risk, but any exposure to valproate is likely not a good idea in pregnancy. Similarly, Tegretol and Trileptal, increased malformation risk with Tegretol, especially neural tube defects and oral facial cleft. Still concern for adverse neurodevelopmental outcomes. Trileptal not as well studied as far as the malformation data, but definitely some concern about neurodevelopmental outcomes. ADHD, autism, significant IQ, relative IQ issues. and any other number of social developmental conditions associated with these medications. So for women who are doing well on these medications, and just in general, we want everybody to be on high dose folate, regardless of their plans to become pregnant. And ideally, everybody should be on an effective contraceptive. So we need to focus our counseling efforts here in some ways and really try and avoid these drugs in pregnancy if possible. Briefly on benzodiazepines, proceed with caution is what I would say. So there's significant associations with low birth weight, neonatal respiratory suppression and need for ventilatory support, increased rates of C-section, preterm delivery and miscarriage, and also some pretty scary single case reports, but with a grain of salt, single case reports of neonatal toxicity syndromes and what appears to be neonatal benzodiazepine withdrawal. In the data that I've reviewed, it looks like Ativan and Klonopin may have a little bit less evidence of congenital anomalies associated than medications like Xanax and Valium. One of the things that we might consider is reducing fetal exposure by using shorter acting agents during pregnancy. But again, we have to remember why we have the patient on a specific medication in the first place. Is it reasonable to put somebody on a short acting benzodiazepine when a longer acting benzodiazepine may be better for their symptoms? And then think about what kind of exposure are we actually having? Is this just a rare PRN exposure that's likely lower risk, or are we talking about chronic daily benzodiazepines during pregnancy? But as we know, we very frequently need to use benzodiazepines to control bipolar 1 symptoms during pregnancy. So something to think about. And then finally, our antipsychotics. So let's talk first about risks to the fetus. The first generations overall are not as often used anymore, but Haldol has long been preferred as an acute treatment for mania in pregnancy. Most women anymore are not going into pregnancy on maintenance with Haldol, so it becomes slightly less relevant when we're talking about relapse prevention for somebody who's doing well. But the efficacy data is fantastic for managing acute mania in pregnancy. And then the risk data is pretty favorable as well, except note that the first generations have an association with increased rates of cardiac malformation. When we talk about the second generation antipsychotics, again, we would really like to have more and better quality data on SGA exposures in pregnancy. But based on what we do have, things look okay so far. That's what I'll say. So the malformation data is pretty reassuring. I will note that there is currently a risk signal that still needs to be investigated further for risperidone. So in one review, they estimated, in one meta-analysis, they estimated an overall and cardiac malformation risk with an adjusted risk ratio of about 1.26. The neurodevelopmental data similarly look pretty good, and there was a recent update from MGH on their registry data that said things still look fairly encouraging based on their data and European registry data as far as neurodevelopmental outcomes. In a 2022 paper, there was an increased adjusted hazard ratio for aripiprazole, interestingly. And again, there has not been enough follow-up to determine what that risk signal might actually indicate, but something to keep in mind. As far as SGAs used most commonly in pregnancy, Seroquel is the most common. Also, interestingly, the SGA with lowest placental passage, so that's encouraging. Abilify, olanzapine, and risperidone are the most common. And then as far as maternal risks, again, we really have to consider confounding when we come up with this data. So SGAs in pregnancy have been associated with preterm delivery, increased rates of unplanned C-sections, forceps and vacuum-assisted vaginal delivery, and NICU stays. When it comes to metabolic syndrome, gestational diabetes associated with these meds, it is not necessarily clear Some meta-analyses have indicated possible dose-related association. And certainly if a patient is on SGAs pre-pregnancy with all the associated metabolic risks accompanying that, they have a higher risk of developing gestational diabetes that may just not have been diagnosed prior to pregnancy as well. As you can imagine, Zyprexa and Seroquel have the strongest association with gestational diabetes. Latuda had a lower estimated risk based on animal data. And we want to focus on appropriate lifestyle interventions and control of medical illnesses prior to pregnancy and during pregnancy if possible. All right, so Maya is back in the office. She's still not pregnant yet. She's doing better. She's stable on her lithium, which is now at a level of 0.8, and her 2 antipsychotics. Based on the counseling that we've done, she'd like to stop risperidone and continue her lithium and quetiapine at these current doses during pregnancy. And this visit, she also wants to revisit the question of breastfeeding and wants more information on her medications and breastfeeding. All right, so how might you counsel Maya based on what you know at this point? She's asked, can we continue these medications just at these doses during pregnancy? So what will you do? Are you going to reassure her that, yes, we're not going to change a thing, we're going to continue these meds during pregnancy? Are you going to counsel her on the possibility that given the changes of pregnancy, symptoms might arise and doses of medications might need to be changed? And are you going to just put a pause on breastfeeding and leave and talk about it closer to delivery? So if we were doing the poll, I would say that this is probably the only one in the presentation that has maybe just one correct response. But think about it for a second, and we'll move on. All right, so to wrap up this visit, we're going to be pretty transparent with Maya about the physiologic changes of pregnancy in layman's terms. And we'll talk about the monitoring of lithium and quetiapine to a different extent that's required in pregnancy, and the real likelihood that we may have to change dosing during pregnancy and postpartum to keep her well, to avoid toxicity, things like that. At this visit, as requested, we are going to revisit Maya's preferences on feeding, talk about the risks and benefits of meds and breastfeeding, which for our presentation, we will put off till a little bit towards the end, but we would talk about that with Maya this visit. And Maya tells you that her preference is to exclusively formula feed, which gives you some important information about what medications you're going to continue. You're more likely to continue. You do make a plan to taper her off risperidone. She's only on 2 milligrams with 300 milligrams of Seroquel. To reduce polypharmacy, you are going to make a plan to taper off and then hopefully continue to monitor for an additional month if possible, just to make sure that she doesn't have any increase in symptoms. And she's planning to continue using condoms at that time. So at her next 1-month follow-up, Maya tells you that she missed her period this week and she has a positive pregnancy test. So things rarely, if ever, go according to plan. We might not have as much time monitoring Maya off of risperidone as we would want. However, we've likely reduced some of the first trimester exposure to polypharmacy that we had. So welcome to the first trimester. Here we go. So let's talk about monitoring some of these agents during pregnancy. So total body water, volume of distribution, and GFR increase significantly during pregnancy from the first trimester through the 3rd trimester, at which point GFR starts to kind of return to normal and kind of precipitously returns to baseline into the postpartum period. So what that means is that we probably are going to have to titrate lithium to have it be an effective mood stabilizer during pregnancy. And again, a monthly level, and then ideally in the 3rd trimester, and especially in the late 3rd trimester, a weekly level. In labor, we have special considerations about lithium. So lithium is very good at equilibrating across the placenta. So maternal serum to cord blood ratio is about 1. And unfortunately, a high neonatal lithium level is associated with some pretty significant concerns. So neonatal lethargy, CNS depression, hypotension, or hypotonia, and flaccidity or floppy baby syndrome are possible, decreased deep tendon reflexes, poor suck, poor Moro reflexes. So we want to avoid having a high neonatal lithium level if possible to avoid some of these complications at birth. Because of these significant complications, again, we want to bring up that it's possible that moms on lithium during pregnancy should be seen by a higher risk OB. And certainly we want to encourage delivery in a hospital that has NICU capability, and also ideally psychiatric options as well, if needed for mom. So in order to reduce this risk, something that we can do is make a plan as part of the birth plan with the patient and the obstetrician for what to do with lithium around the time of delivery and postpartum. And that would probably involve holding the lithium altogether at onset of spontaneous labor or a day or two before a scheduled C-section or induction, and then resuming it at a decreased dose, a significantly decreased dose after delivery as soon as mom is medically stable. And what I mean by decreased dose is there are different opinions on this, but considering that some patients may get up to very high doses of lithium to maintain stability during pregnancy, we're talking 1,800 milligrams and up at times, we might consider having that dose at delivery. Or if patients on a more reasonable pregnancy dose, think about just going back to pre-pregnancy effective dose immediately after delivery as soon as mom is medically stable. We also want to emphasize that postpartum is a very high risk period for relapse. So the recommendation is dosing to the higher end of therapeutic lithium level postpartum, if possible, while weighing the risks of toxicity as mom's physiology adjusts to being postpartum. Lamotrigine, similar story. So there's increased hepatic metabolism and renal excretion during pregnancy, leading to a significantly lower lamotrigine level, kind of similar to the metabolic effects of combined oral contraceptives, as you can imagine. Some women will need up to double their baseline lamotrigine level during pregnancy to maintain efficacy as a result of these metabolic changes and renal changes. And again, this begins in the first trimester and continues through the third trimester. So we are very likely to need to titrate. And then post-pregnancy, we want to taper quickly to avoid toxicity and hypersensitivity reaction. I've seen it recommended that 25% of the dose increase be tapered off on postpartum day 1, but we want to find a plan to get back to that pre-pregnancy dose postpartum, all the while monitoring very closely for toxicity and rash. Very briefly, antipsychotics are affected by cytochrome P450 and glucuronidation changes during pregnancy. Read up on any specific agent to find out how changes of pregnancy might affect it. Watch for breakthrough symptoms and for side effects of medications. All right, Maya is back in our office. It's the second trimester, and she's here for an urgent visit. Her husband has brought her in because she's depressed. She's been more self-critical, she's been more tearful, not eating quite as much, and having more trouble falling asleep over the past 2 weeks. She did have to miss a month of her therapy visits because she's taken on more overtime work, and they are having some financial stress in preparing for a newborn. Her trough lithium level is 0.6 on 900 milligrams at bedtime. So we're wanting to think about acute symptoms. And then Maya also has a question about her quetiapine at this visit. She's asked about whether it might be stopped in the third trimester due to concerns about PNAS. So what needs to be accomplished at this visit? What needs to be accomplished at this visit? What would your top priority be? You're going to recommend med adjustment to address her acute symptoms, get her rescheduled for therapy and talk directly with the therapist about what's going on, revisit some of those lifestyle modifications, Think about her emergency plan if symptoms get worse. You're going to have a brief counseling on PNAS. And at this point, would you think about starting to taper off Seroquel prior to the 3rd trimester? Think about where you lean. All right, so it might be obvious at this point, my priority would be treating acute symptoms expeditiously. And then we are going to do all of these other things, ideally at this visit, with the exception of tapering her off of quetiapine. And let me explain why. So just a brief comment on PNAS, poor neonatal adaptation syndrome. This is something that's been reported with SRIs, SGAs, the seizure drugs, benzodiazepines. The FDA actually placed a warning label on SGAs in 2011 for both PNAS and extrapyramidal symptoms for babies of moms who take them in pregnancy. So this symptoms might include sleep disturbance, irritability, jitteriness, problems with feeding, increased muscle tone and myoclonus, some mild respiratory distress, and a number of other more vague, nonspecific fetal distress symptoms. It's usually a time-limited issue with an average duration of 2 days. Many of these babies do need NICU support, but we really don't totally understand what PNAS represents. So is this something that's related to early pregnancy exposure of medications? Does it represent kind of discontinuation syndrome, like what we might see in adults after delivery? Is this acute toxicity from neonatal presence of medication at delivery? Or is it something else? Are there some other contributing factors outside of the specific medication exposure? So in an interesting assessment of registry data, when comparing outcomes for neonates of moms who continued SRIs specifically through pregnancy and through delivery with moms who had SRIs tapered off completely before the final 2 weeks before delivery, the rates of PNAS were similar. So it did not have a significant effect. So that might lead us to consider that maybe this is not necessarily a withdrawal or discontinuation syndrome, possibly, maybe less likely a toxicity syndrome. There is some suspicion that whatever the pathway is, it might actually be similar for these various agents, possibly. And then we really have to consider the contribution of maternal mental illness and all the associated risk factors that might contribute to some of these neonatal distress problems. All right, so Maya is following up because we changed her medication. We titrated her to 1,200 milligrams. Her new trough is 0.8. She's on board with continuing quetiapine, 300 milligrams at bedtime through delivery, since we talked about what PNAS is and the greater risk associated with tapering off Seroquel, especially as she was symptomatic during pregnancy, compared with the risks of PNAS. She's back in therapy and her symptoms are fortunately improved. So we schedule her next follow-up visit. And then we also schedule the critical last planned visit of pregnancy in the late 3rd trimester. So I'm going to use this New Yorker cartoon as a way to help us kind of jump forward in time from the 2nd trimester to the 3rd trimester and into the postpartum. And Maya is now in your office for her last planned visit of pregnancy at 34 weeks. She's still doing well on lithium and Seroquel. She's still doing well in therapy, monitoring symptoms appropriately, very excited about meeting the baby, but appropriately concerned about the risks with delivery and the risk of postpartum relapse. Importantly, at this visit, she is also having some second thoughts about her feeding plan, has some questions about breastfeeding, and really wants to revisit the risks versus benefits of breastfeeding at this visit. So, what do you want to accomplish this visit? If you could only do one thing, what would be the most important thing that you did during or immediately after this visit? And what are some other things that you would put on the list? How might you prioritize among all of these things? Counseling on relapse, warning signs and emergency plans, reassuring Maya about her postpartum risk, coordinating with OB about the lithium dosing at delivery and postpartum, making some specific recommendations in counseling about breastfeeding, and maybe doing even a brief therapeutic intervention about breastfeeding. Take a second to think, if you could only do one, what would be the most critical to do at this visit? So I'm going to argue, kind of for safety reasons, like we already discussed, that making that birth plan on lithium dosing with OB is going to be really critical. And then following that, I would give probably A and D some equal weight here. So we're definitely going to talk about relapse prevention postpartum, and we're definitely going to talk about medications and breastfeeding and do some counseling there. And then the others are kind of going along with those. So let's see what that might look like. So postpartum is a high risk period in bipolar 1 disorder. For both the bipolar disorders, the overall postpartum relapse risk is almost up to 40%, significantly higher if untreated during and after pregnancy. If there's no prophylactic medication, significantly higher risk of postpartum relapse. So again, during this final planned visit of pregnancy, we're going to plan for the challenges that we can assume will come up postpartum and see if we can modify any of those lifestyle risk factors. Highlighting sleep, probably the most critical thing, maintaining the circadian rhythm. Nighttime infant care is a big one. Is there anyone that can assist with nighttime feeding, nighttime infant care to help mom maintain as routine of a sleep schedule as possible? Other elements of the routine are medication dosing, making sure that things stay on track there. Role transition, a great opportunity for discussion and therapy, and then continuing stress management as able, pulling in the support system. As far as symptom monitoring, we continue as we did during pregnancy, with an emphasis on emergency planning, given the heightened risk of relapse postpartum, involving the support system, making and continuing a rescue medication plan as we do for all bipolar patients, and thinking about a tiered response plan postpartum if symptoms arise, now with the consideration that there's a baby involved, and how do we have an emergency plan that involves childcare potentially to allow mom to get treatment if needed. We really want to emphasize at this visit the warning symptoms of postpartum psychosis, a lot of crossover with mania with psychosis, which for many bipolar patients, this is essentially what this will represent. Just to highlight that in postpartum psychosis, we may see some interesting delirium-like symptoms, higher risk of confusion and distractibility, and more of an obsessional bent to some of the delusions. And in this period, any thoughts, well, really at any period, but just to remember that thoughts of suicide or infanticide are an emergency and require emergent psychiatric intervention. Very high suicide and infanticide rates, unfortunately, in postpartum psychosis. We could talk a little bit in the Q&A if anybody is interested. But as far as differentiating between, postpartum OCD and postpartum psychosis, are these benign intrusive thoughts, or are these symptoms of, actual suicide and infanticide risk with postpartum psychosis? I think for the purposes of someone who has not had those symptoms evaluated yet, it should still be considered an emergency because, again, this period is so high risk. All right, let's take a moment to talk about medications in breastfeeding. So in general, we want to make sure that we're looking out for the same side effects in the infant that are of concern in mom. Similar lab monitoring is going to be involved depending on the agent or category of agents. And then we want to watch for nonspecific fetal distress symptoms, sedation, feeding problems, irritability, etc. I'm going to come down on this side for the purposes of this presentation based on the available data at this point and say that lithium is not recommended during breastfeeding. It's one of the few agents that that's the case for, but lithium is not recommended. Remember that lithium equilibrates very well, so that includes equilibration into the breast milk. There's a rule of halves that says that mom's serum level is halved in the breast milk, and that level is halved in the infant. So infants may get up to a quarter to up to 30% of mom's serum level of lithium. So infant levels can be fairly high. The lab monitoring, as you can imagine, has to be done in concert with a pediatrician. It can be pretty onerous for mom to go in and get necessary labs drawn in the infant, TSH, BMP, pretty frequent lithium levels. And remember that the neonatal kidneys are still developing, and they may be particularly vulnerable to renal toxicity associated with lithium. And we do have, again, just, case reports, but we have seen some pretty dramatic outcomes of neonatal distress and infant distress with lithium. As far as the other meds that we commonly use in bipolar 1, so far, the data is generally fairly reassuring, but again, as we'll talk about in the next slide, we have to consider, why are we making this exposure? Do we need to? But at any rate, the relative infant dose of AEDs varies somewhat. Lamotrigine, interestingly, may have a higher relative infant dose than some of the other AEDs, all of which are generally approved in breastfeeding. Lamotrigine is a medication in which breastfeeding is actually encouraged by the AAP. The data is pretty favorable so far as infant outcomes. Benzodiazepines have a lower relative infant dose, and the data is fairly favorable so far. Antipsychotics generally have a low relative infant dose with favorable data. Just remember that Abilify, as a partial agonist, can have some impact on lactation. And then clozapine is kind of the exception here. It has a higher relative infant dose. And remember that especially in a neonatal infant with a developing immune system, the potential adverse effects of clozapine are more severe. And again, you're talking about onerous lab monitoring. Remember, this is a newborn. It's essentially like they're a person starting clozapine for the first time. And so you're going to have to get at a minimum weekly labs. Not a lot of moms can bring a baby to do that. All right, general breastfeeding counseling in bipolar 1. So we know, and we have all heard and learned through the course of our medical training, that there are significant breastfeeding benefits, both for infant and for mom. On the other hand, when it comes to moms with bipolar 1 disorder, we really have to weigh those benefits against the illness-specific risks. And what I really want to highlight here is that breastfeeding can contribute to circadian rhythm disturbance for mom. We also need to think about why we assume the risks of exposure. And it just is the case in general. And there are always going to be exceptions, but in general, it's the case that it's easier to avoid breastfeeding exposures by not breastfeeding than it is to avoid in utero exposures, which in many cases may be unavoidable. We also, just a brief note, want to think about not only the breastfeeding risks associated with meds in the postpartum period, but also what other responsibilities mom might have. Do we really want mom to be on meds that are sedating for her when she has primary childcare responsibilities? Definitely something to discuss. Talking about resources, so there are many people who are unable to breastfeed for many reasons, and even outside of a psychiatric diagnosis and med exposure, many reasons for people not to be able to breastfeed, and we want to make them aware of formula banks and donor breast milk banks. On the other hand, we also have to consider that we live in a time with formula shortages. We have to think about whether somebody might have personal beliefs or feelings about receiving donor milk, for example, and then really significantly ask about and discuss any cultural perspectives on breastfeeding. And this is kind of an opportunity for a brief CPT intervention. During this stage of counseling, we want to be really curious about what things this discussion is bringing up for the patient. Things go back and forth, and the medical community can be kind of reactionary on topics that affect moms. Breastfeeding is one of those hot button issues. And so people are receiving a lot of messaging, regardless of whether they're pregnant, about the value of breastfeeding and what it might mean about you if you're not able to breastfeed. So it's important to be curious, does this patient have any deeply held beliefs about breastfeeding, or effects on her self-image about the idea that she might not want to breastfeed or not be able to breastfeed? And can we address those with some cognitive restructuring if appropriate? And so I'll just close this section on a motto that maybe fed is actually best, kind of countering that possibly toxic motto that breast is best. So fed is best really by any means for the infant. And then for mom, as we've talked about, well is best, euthymia is best, really for everyone involved. All right, so here's a little slide about Maya. Postpartum, ideally, this is kind of our ideal outcome. She's sleeping, she's doing well, she's bonding with the infant. Very sweet. So just a brief summary, kind of the high points that I want to leave you all with. In my opinion, when it comes to these situations, maternal euthymia has got to be the guiding star of management. These decisions are incredibly collaborative and highly individual in nature. We want to make sure that the patient support system and other specialists are involved from the beginning. I don't want to de-emphasize in any way the importance of lifestyle risk factor management and getting people involved in therapy for relapse prevention in addition to our medication interventions. We really want to think about, as we always do, using an effective medication or medications at effective doses. So as Dr. Al-Malik has said many times in our patients in general, why would we expose someone to the risks associated with a medication without dosing to give them the benefit of the medication? Just a couple other high points: avoid the AEDs besides Lamictal in pregnancy if at all possible. And then consider the risks associated with lithium and weigh them against your patient's background. So is this someone who just really does well on lithium and should probably remain on it? Something to consider. And then probably avoid lithium in breastfeeding based on the available data. And then finally, embrace ambivalence. Embrace the fact that there's no risk-free option in these situations. There's very rarely going to be one right answer. And as kind of a parting thought, I would say that this is an element that I think working with pregnant patients can kind of teach us about working with psychiatric patients in general. Because regardless of whether somebody is pregnant or not, there very rarely will be a risk-free option. And we have that opportunity again to house some of that ambivalence and be, receiving some of that ambivalence for the patient while we're working with them to make the best choices for them on an individual basis. These are some free high-yield resources about meds and pregnancy and breastfeeding and other issues of reproductive psychiatry. I'm going to skip through quickly because I definitely went over time and I want to make sure we can have a little bit of discussion. And then I'm just going to speed through my references again. Anyone can have my slides that wants them. And then I just want to take just a minute, since I'm at the end here, to really sincerely thank everyone who has supported me on this residency journey. First and foremost, thanks to my wonderful parents, my brother, my husband, Kevin, and our dog, Lentil, and my friends who have kept me in touch with the world outside of medicine. Sincerest thanks to Dr. Hettinger and her excellent mentorship in women's mood and anxiety disorders and her help with this presentation. Thanks to my psychotherapy supervisors, Dr. David Casey, Dr. Wright, and Dr. Wood. Thanks to Dr. Wright again and Dr. Donna Sudak for their mentorship in teaching and practicing CBT, to all the faculty, to the social workers and staff who have been so generous with their time and wisdom over the past 4 years. Christy, you are an angel. And finally, thanks to my co-residents for their humor, insight, teamwork, and support during both the minor and the very major challenges of the past 4 years. Thank you so much. And now we have time for some questions.
Thank you, Dr. Perlin, for a wonderful presentation. We'll promote some of the attendees to panelists. And if anybody has any questions, they can raise their hand or leave it in the Q&A.
Don't worry if there, I think Dr. Rabbani has a question.
Am I unmuted?
No, I can hear you, Dr. Rabbani.
Okay. Thank you for this wonderful presentation. Lots of information. My question is about the breastfeeding. Is there any possibility of to breastfeed them, but less than kind of all the time, to have some benefits of breastfeeding, but not to have side effects of lithium and other medications? Is there any thought about that?
Yes, I definitely have some thoughts about that. So I would say it definitely depends on the agent. When it comes to lithium, I think that the idea of, for example, pumping and dumping, depending on the timing of medication dosing, is really difficult to actually kind of calculate out. And it's an additional, it could be an additional stressor for the patient to try and time those things out. So lithium, I would say, pretty difficult to counteract the risks in breastfeeding by pumping and dumping. By and large, pumping and dumping to avoid medication exposure is not something that's recommended by the greater quorum of reproductive psychiatrists. On the other hand, when it comes to meds that are lower risk, or that we just at this point don't have the risk data on, I would say that it actually might be pretty reasonable to have a daytime breastfeeding schedule and pumping schedule, as long as somebody else can handle nighttime feeds, so that mom is able to get enough sleep to manage that kind of risk factor.
Thank you very much. Appreciate it.
Hi, Rina. Hi, Dr. Huang. Very
Dr.
nice talk. Yeah, would you please send me a copy of the slides, please?
Yes, sir.
It's very comprehensive. So the question is, you're saying we need to learn to tolerate a lot of ambivalence. But by the end of the day, if some bad outcome happen, and we went through all these exercises, bad things still happen, how do we navigate that?
I think that the way we navigate it is preemptively through our counseling. So giving as much information as we can up front, so that we collaboratively essentially have the opportunity to say, this is an outcome that may happen, and what is the likelihood that that might happen depending on our exposure, and then being very transparent that we're weighing that against the really significant risk of going without treatment during pregnancy. So bad outcomes do happen. And as with anything else in psychiatry, there's a certain amount of medical legal risk associated with those things. But I think that as with any therapeutic alliance, that alliance is really the central point. So coming from a perspective where we give as much information as we have available, but also knowing what we're weighing those risks against.
Good. Thank you so much.
Dr. Risky had a comment in the chat saying thank you for your amazing presentation, and that it would be a great topic to get more formal education on in residency.
Thanks, Ariel. If there is a break in the questions, don't worry, because I have several topics that I have slides on at the end of this presentation that I wasn't able to get to. So we have the opportunity to talk a little bit about a couple things, ECT, data, postpartum psychosis, whatever anybody is interested in. Let me know if any of those sound appealing.
If you would like to be promoted to a panelist or have any questions, just please raise your hand.
Rina, can we hear the ECT section?
Yes, let's do that. And then I think Syed has a question. I saw your hand. Maybe that was a mistake. Dr. Abbas, did you have a question?
I did.
Okay.
Thank you so much, Dr. Perlin, for that excellent comprehensive presentation. I definitely learned a lot. And my only question was, you're certainly going to have patients at some point in your career that will be spooked by all the information that you give them, and then will opt to completely not take any medicines during pregnancy. And then during your research, did you come across, what the risk factors were for untreated, and how that impacts pregnancy during the terms for untreated, bipolar, untreated depression, obviously mania, you don't want that during pregnancy, but at least as far as depressive episodes go.
Oh, yes. So the risks associated with having an untreated episode during pregnancy. I have come across data on that. It's very variable. And I think some of that was included on the risk discussion slide specifically for that purpose. So there are kind of inherent risks in going untreated. I tend to think that those risks were associated with somebody actually being symptomatic during pregnancy, but that might not necessarily be the case for some of those points. And then just in general, I think we have wiggle room to act based on our clinical experience here and understanding all of the exposures that come along with an acute episode during or outside of pregnancy that we talked about. So we know, for example, that to stabilize an acute depressive episode or an acute manic episode is going to require higher dose medications and often polypharmacy. So we actually can pull in the risk data from the medications that we have and say, hey, we're going to actually be using higher dose meds. We're going to be using multiple agents. So that's already a huge exposure. And again, most of those relapses were depressive in nature, and the majority of them occurred in the first trimester. So we're still talking about significant teratogenicity risk. So I don't know if that specifically answers that question, but as far as counseling goes, I think we're not only going to counsel on meds risks, we're going to talk to them very transparently about the risk that they would have a relapse if they go unmedicated and the risks associated with that relapse.
Yeah, and then the outcomes then associated with uncontrolled, bipolar depression during pregnancy. Did you have some data about the outcomes with, the neonate and all that?
I don't think I've included those specifically. I know that at least one or two of the papers on the general course of bipolar in pregnancy that I've included probably have more outcome data on that. But I will say unequivocally that the neurodevelopmental data that we have reflects that if mom gets depressed or manic during or after pregnancy, there are measurable neurodevelopmental adverse outcomes for the child. So that's one that I would emphasize, because I think a lot of moms now are more aware of neurodevelopmental data with the meds and risks of autism and ADHD, for example. And so we have to be very transparent. Again, the overall message is that euthymia during pregnancy predicts postpartum euthymia, predicts child neurodevelopmental outcomes.
Yeah. Thank you.
Thank you. And then Dr. Kostrowski wanted to learn a little bit more about ECT, which I also want to talk about. So as everybody probably knows, because we do talk about this one more, I think, with regards to pregnancy, it's a pretty good proposition. So the safety data is really reassuring as far as gestational outcomes, maternal outcomes, and fetal outcomes, highly effective for acute manic episodes and for depressive episodes during and outside of pregnancy. There are some single case reports that have some pretty significant outcomes, but not necessarily attributable to the ECT themselves, with the exception of one very tragic case of maternal status epilepticus that led to miscarriage. And then, so again, if somebody is on maintenance ECT prior to pregnancy, the safety data and efficacy data indicates that it's reasonable to continue their maintenance ECT during pregnancy, and then also reasonable to offer ECT for acute episodes during pregnancy. The one kind of other thing to consider is that as far as the ECT team, psychiatry and anesthesia, it's probably a good idea to have obstetrics on board around the time of the actual ECT treatment as well, to do a pre-procedure pelvic exam to assess whether there's any fluid loss, vaginal bleeding, any dilation before the treatment. And then to offer fetal heart monitoring depending on stage of pregnancy during the procedure as well. And then later in pregnancy, we have to consider that there is an increased regurgitation risk, and weighing the risks and benefits, it may be worthwhile to consider intubation if mom is pretty late term in pregnancy. So something to think about. Any other questions? All right, well, I know RAC is happening. If nobody else has any questions, we probably can wrap up. Thank you so much. And if anybody has any questions outside of the presentation, I would be delighted to talk about this stuff at pretty much any time.